have some conversation before we move on to the SOUL study. Thanks for joining us. Enjoy the presentations. We'll be back in a little bit. All right, everybody. Welcome again to our webinar on the new semaglutide trials. But I think it's important, before we get to what's really interesting and new, to understand what the current state of medical therapies are. So I'm going to review that now for the next few minutes. In 2015, only 10 years ago, our major therapies included the ones that you see on the list here. Aspirin or clopidogrel as antiplatelet therapy, statins, cilostazol for symptoms, and ramipril for blood pressure or vascular conditioning. And as you'll notice, not one medical therapy had a limb benefit there. They were all to reduce major adverse cardiovascular events. Fast forward 10 years ahead, and what you can see is that we've had important additions to therapy since then. These include the PCSK9 inhibitors, rivaroxaban in an arterial dose, and even liraglutide as a GLP-1 receptor agonist. I think what I'll do is I'll review the data for these, show you where we are now, and tell you that we are now on the point where we can actually affect not just lives, but limbs as well. And medical therapy has made huge strides in only a decade. So let me go through prehistoric times when many of our therapies really came into being. The first big change in our therapy was probably now 30 years ago, and this is the Capri trial, and it was a 19,000-person trial comparing clopidogrel to aspirin, and you can see that there was a modest benefit of clopidogrel over aspirin in cumulative risk of adverse events over the course of about 3 years. And the reason this trial really took off is you can see on the left that there seemed to be an outsized benefit for peripheral artery disease. Now, I'll tell you, I'm not sure we would have been able to do this analysis and get it published now, but at the time, it created quite a stir and made it so that clopidogrel became an important medical therapy for peripheral artery disease. Despite that, most people continued to use aspirin. The next big change was in 2002 with the publication of the heart protection study, which was simvastatin versus placebo. And if you take a look on the right side of the screen with this plot, you can see that patients who had no prior coronary heart disease, but did have peripheral vascular disease, had a similar relative risk reduction for major adverse cardiovascular events, coronary heart disease events, as every other group of patients with atherosclerosis. You can take a look at the data that was published several years later in the Journal of Vascular Surgery, which looked at the PAD population specifically. And there was a reduction in strokes and a reduction in major coronary events and a reduction in major vascular events. There was a reduction in revascularization, but this was primarily carotid and coronary. There was no reduction in lower extremity events, amputations, or even AAA events. So this is the one randomized trial that tested peripheral artery disease and statins. And remember, this is 2002. It was a seminal trial, and it only modestly changed practice. The HOPE trial came out around the same time in 2004. This is ramipril versus placebo as a atherosclerosis medication. This is in patients specifically with PAD, then called PVD. And they separated those patients into two different groups. One of them was the patients who had symptoms of peripheral artery disease. And you can see here on top that the addition of ramipril significantly reduced the rate of events. And if you take a look at the bottom, those were all people with an ankle brachial index of under 0.9, so they would qualify as having PAD. And again, there was a significant reduction in events. This is like heart attack, stroke, and death stuff. So ramipril had a really significant impact, and we didn't really start using it. Just to take a look specifically at the event reductions, you can see the primary event reductions, particularly in the patients with symptomatic disease, dropped from nearly 26% to 20%. These were all consistent reductions in MI, stroke, all-cause death, revascularization. The same was true in the asymptomatic PAD patients with a low ABI, just the numbers were a little bit lower. High overall for sure, but a bit lower than patients who had clinically advanced disease. Cilostazol for a long time was the only medication we had that improved walking distance, although many patients stopped it because they developed deleterious GI effects or rapid heart rates, and many people couldn't be put on it because they had heart failure. But what you can see here is that over the course of 24 weeks, Salocitol increased walking distance compared to placebo, and this trial also nicely demonstrates the uselessness of pentoxifylline. All right. All those medications came about 25 years ago, and we can wonder about their use and what we do with them. But remember, we've had a quarter century to get in place at least well-established guideline-recommended therapies at the time. Let's move into modern times so we can see what we have now available and hopefully won't take the same amount of time for use. LDL lowering with evolocumab, a PCSK9 inhibitor, demonstrated a significant benefit in patients with PAD. These are the PAD patients. These are just limb events alone. To make the point that there's a specific benefit here, remember, if you had, you were already on a statin to get into this trial, you were already on a high dose or maximally tolerated statin, and your LDL was above 70, not above 130 or 100, above 70. And despite that, with the additional LDL lowering with this medication, limb event benefit. COMPASS is the first trial that demonstrated that low-dose arterial dose rivaroxaban at 2.5 milligrams twice daily in concert with baby aspirin was so impressive that they stopped the trial early because of the reduction in the cumulative risk of death, stroke, or myocardial infarction, and this included a significant number of PAD patients. The PAD patients were called out by Sonia Anand in Lancet several years later, and what you can see here is that there was a definite benefit in major adverse cardiovascular events on the left and major adverse limb events on the right. So how often are we using this medical therapy, dual pathway inhibition? Not very much. Voyager continued this streak for rivaroxaban, looking at patients after revascularization, and it reduced significantly the rate of adverse lower extremity events. Not surprising, if you came in requiring a revascularization, most of the events were leg events, in the same way that if you come in with a heart attack, most of your events are heart events, and if you come in with a stroke, most of them are cerebrovascular events afterwards. This worked quite well. Now we had evidence that there's treatments for patients both in the chronic phase and then the acute phase after revascularization. GLP-1 agonism had its first sense that it's maybe a special drug class. This is GLP-1 agonism with liraglutide looking at diabetic foot and amputation. I will note here that there was no difference in revascularization, but it seems like the key effect of these drugs in the diabetic foot certainly was the reduction in infection and the reduction in infection in underlying structures, giving us a sense that there may be a benefit here for these agents in these patients. This is a look back at the study, not a prospective analysis, which we'll talk about later. Now, here's the real problem. This is one of those studies that demonstrated why we do something today, we find out the information today, and patients don't benefit for a long time. This was just the adoption of new medical therapies. This is a wide variety of therapies in different settings. And you can see here that the average to get to the point where most physicians were prescribing these medications was 10 to 17 years. Some of them went up really quickly if there was no agents there. Some of them never reached escape velocity. But what you can see here is that we are really bad for at least a decade in getting new therapies. And before you sort of nod and say, that's not me, this is the medical therapy use at baseline in Best CLI. And you can see that only 70% of the patients were on one lipid-lowering agent, 70% of the patients were on one antiplatelet agent, and 38% of the patients had their diabetes controlled. I am really hopeful that as we hear the next coming presentations, we hear this new, really exciting data, that we can bring our medical therapy up to speed and benefit our patients sometime before 2040. We are at the point now where we are reaching escape velocity, and I'm really excited for both Dr. McGuire's and Dr. Bonaca's presentations, so we can see how metabolic therapy with GLP-1 agonism can make a tremendous difference, and we have the large randomized prospective control studies to prove it. Thank you for your attention. And I look forward to the talks, and hopefully you do too.
Hi, my name is Marc Bonaca, and it's an honor to present the STRIDE trial primary results, semaglutide and walking capacity in patients with symptomatic PAD. By way of background, peripheral artery disease is a prevalent condition impacting more than 230 million individuals globally. It's one of the earliest and most severe consequences of type 2 diabetes, and combined diabetes and PAD present a very clinically challenging condition with small vessel disease and disease below the knee, where functional impairment is significant and is a dominant morbidity. Now, we have class 1 indicated diabetes drugs in the guidelines, but none of them are preferred because neither have shown PAD specific benefits. And our only class 1 indicated therapy for function is cilostazol, based on a 40-meter improvement on a treadmill, but without cardiovascular benefits. And because it has a black box warning for heart failure, it's widely underutilized. Now, PAD is a complex pathobiology, as you can see on the left side of the slide, and inflammation, cardiometabolic disease, these all lead to an increased incidence of PAD, accelerated progression, atherosclerosis, and microvascular disease, and then progressive functional decline. Now, semaglutide and GLP-1 agonists have a host of demonstrated benefits, including cardiometabolic benefits, reductions in inflammations, benefits for MACE, kidney complications, and even in one study, a reduction in amputations. And so we asked the question of whether semaglutide in patients with symptomatic PAD would improve function, symptoms, hemodynamics, and lower the risk of revascularization or progressive disease. This is the STRIDE trial design. We enrolled patients who had claudication, diabetes, and peripheral artery disease, and randomized them to semaglutide 1 milligram weekly versus placebo. And we did robust assessments over the course of a year, including constant load treadmill at baseline, 26 weeks, 52 weeks, and then one test at 57 weeks after the last dose of therapy. We enrolled patients with early stage PAD, as you can see on the right, so Fontan 2A. So they had to be able to walk at least 200 meters, but they had to be limited and no more than 600 meters on an incline on the treadmill. They had to have abnormal ABI, and then we excluded patients with unstable cardiovascular conditions. Our outcomes are listed here in green. Primary outcome was function, so change in maximal walking distance from baseline to week 52. In orange, we have symptoms in terms of pain-free walking distance. We pre-specified quality of life using VASQ-QOL6 and the SF-36 physical functioning domain. We looked at mechanism in terms of biomarkers and ABI, and then clinical impact in terms of outcomes. And the constant load treadmill was the primary endpoint. You can see that next to the 6-minute walk test. And just to put into context, it's about double the work when you walk on a 12% grade versus a flat surface at the same speed. And the constant load treadmill has no limit to distance. It's a true distance test, while the 6-minute walk test is a speed test. This is a global trial. We had patients enrolled in 20 countries and 112 sites, and we enrolled about 800 patients. The trial had a robust ascertainment of endpoints. You can see over 93% completed the trial, and less than 10 were lost to follow-up in each arm. You can see our baseline characteristics here, and I'll highlight that this is a very common population you may see in your clinic with all the typical comorbidities. They did have a high degree of smoking, so you can see about 2/3 were current or former smokers, and then very high utilization of indicated medical therapies, including lipid lowering and antithrombotics, and having a median LDL cholesterol that was 69 milligrams per deciliter, which was in tune with the guidelines. In terms of baseline function, you can see on this slide, they had abnormal hemodynamics, but I think what's most striking is even for early stage PAD, patients had a very limited maximal and pain-free walking distance, around 1/10 of a mile. And that was reflected in the quality of life on the right, where the overwhelming majority noted disability that was mild, and most with moderate or severe disability. All right, so the primary endpoint of STRIDE is shown here. And you can see in the gray bar, patients who were randomized to placebo had a slight improvement in function, likely due to the excellent medical care they were receiving and some drop into revascularization, as well as a learning effect on the treadmill. Semaglutide was superior. Benefit was apparent at 6 months, and the curves continued to diverge over the course of the 1 year of treatment. The delta that the patients appreciated in the context of semaglutide, the improvement was 40 meters as a mean improvement relative to placebo, and that's shown at the far right. We did a robust internal anchor measure to determine whether this difference was clinically impactful or clinically meaningful. And you can see here that this was highly statistically significant with a p-value of 0.002. So semaglutide improved function and of a magnitude that was clinically meaningful. In terms of subgroups, we saw that the benefits were consistent across age, sex, region, hemoglobin A1C, and importantly, BMI. Even people who had a lower BMI below the median had the same benefit. We also tried to understand a little bit of what mediated the benefit. So you can see here that body weight change was associated with an improvement in function. If you lose weight, you do walk a little bit better, but that relationship was extremely weak, with a Spearman's of around 1.2 to 1.4 in both groups. And that was too weak to explain the magnitude of benefit we observed in the trial. So it was not weight loss that drove this. We also saw improvements in A1C and blood pressure, as we would expect with this class of medication. Now, we looked at all the primary and secondary outcomes that were pre-specified, and in this trial, every single one of them was improved with a statistically significant p-value. In green, you can see that the various looks at function, whether it was on treatment, off treatment, symptoms in terms of pain-free walking distance were all significantly improved. Quality of life was significantly improved, both with the VascuQoL-6 and the SF-36, and we even saw a statistically significant improvement in ABI from around 0.76 or 0.77 to 0.81. Now, we asked the question of, did these benefits also come with a change in the course of disease, of progression of outcomes? And you can see on the left a composite that we looked at, which was people falling into the need for rescue, either revascularization or medication, a major adverse limb event, or mortality. And you can see that there was a 54% lower rate, and it was statistically significant with semaglutide. And on the right side of the slide, you can see the consistency amongst the different components of this endpoint. In terms of safety, SAEs were balanced between arms. There were more of the typical adverse events you'd expect with a GLP-1 agonist, including GI and appetite, but nothing severe like pancreatitis that was different between the arms. So overall consistent with the expected safety profile of semaglutide. So in summary, semaglutide in patients with symptomatic PAD now adds to the database of information for this drug class. This is a vascular drug. It improved function. It was clinically meaningful in terms of its impact. It improved symptoms and quality of life, reduced disease progression, improved ABI, and with a safety profile consistent with other studies. And so this now adds to the other benefits shown on the left side of the slide in terms of kidney, cardiovascular, and cardiometabolic benefits. So in conclusion, semaglutide is the first therapy to reduce major adverse cardiovascular events, improve cardiometabolic and kidney outcomes, and improve walking capacity, symptoms, and PAD or function-related quality of life in patients with peripheral artery disease and type 2 diabetes. On the right side of the slide, you can see now the circle around the leg or peripheral artery disease, which joins the other benefits across the cardiometabolic spectrum, across the cardiac, kidney, and other benefits of the drug. And it, I think, is an important finding for therapies where we always strive to make people feel better, function better, or survive better. And we now have a therapy in the vascular domain that can help our patients. Thank you for your attention.
Excellent. All right, so let's go back to the panel now and have some discussion about what we've just heard, both Dr. Bonaca's and my talk. I'm going to start off with a very simple question. And I'm going to lob it first to Dr. Kadian-Dodov. When you talk to your patients with PAD, how do you get them until a trial like this one to take the standard medications? What is your conversation like about they're coming in with limb problems and you're giving them medicines for their heart?
Yeah, it's a fantastic question. I think it starts with the discussion that PAD is a manifestation of atherosclerosis, which is a total body disease, and that we know from the data that our patients with PAD are particularly at risk for the uh, outcomes of MI and stroke. So we need to kind of attack it all with the medications that we have in order to prevent those outcomes. And by doing that, I think patients are on board with doing things like managing risk factors, blood pressure, cholesterol, diabetes, etc.
There are a bunch of different specialties on the call, and I was wondering if you guys would just tell the rest of the audience what do you think your responsibility is as an interventionist, surgical, radiologic, or cardiovascular, um, in medical therapy for these patients? Is it the job of someone who's going to do revascularization to also make sure they have great medical therapy on board? Anybody can speak up first.
I'll start with that, and I think it's very important. A lot of times we see patients that we're not going to intervene on, but putting them on the right therapy, I think, is critical. I think it is a role, it's our role, first of all, to check what medications they're taking. I'm being prepared to, add aspirin, add a statin, uh, make sure their blood pressure control is adequate. Making the call to their primary, making sure they know what you're changing, or asking them to make those changes. I think it's really important. A lot of times I tell my patients, hey, you're doing great. We're not going to do anything about what's going on right now, but really we want to prevent things from getting worse, and more importantly, heart attack and stroke. And that's usually those two buzzwords are the ones that make my patients listen a little better.
Josh, I would agree. I think that, many times as interventional cardiologists, we're the only cardiovascular specialists that many of these patients will see, and we are their panvascular doctors. And so, we are often on the hook to get them on optimal medical therapy and then continue to follow them. And we do that to the best of our ability. I think the question, though, that is relevant is the issue of polypharmacy. And, we know that the compliance of most of our patients is inversely proportionate to the number of meds they're on. And so as we layer on more and more complex therapies, we're going to have to prioritize those which we think are the most important, and then get down to the ones that we think are important but perhaps dispensable. And that's not necessarily a trivial discussion with these patients. We have less and less time to see patients and more education to provide them in the office. So, we often are reliant on our APPs, our nurse practitioners and physician assistants and other office staff to help with that kind of education. And that's, I think, part of the conversation we have to have. How do we execute on what we know is excellent medical therapy in the limited amount of time and with the limited resources we have? Not to mention the amount of time I spent doing pre-authorizations for some of these medications.
I'll
Brian, how about you?
speak up in a second. Yeah, speaking maybe from a surgical perspective as a vascular surgeon, I think that unlike many of our non-surgeon interventionalists in the group, when you go into surgery residency after medical school, in some ways you sort of put all the medicines behind you and think that you're only going to do surgery and take this immediate active role in a patient's care. But certainly in vascular surgery and anyone who deals with cardiovascular disease, we just know that's a fallacy. And as vascular surgeons, we oftentimes spend a significant amount of our time serving as a primary care physician for a lot of our patients, unless they're well plugged in with a good internal medicine doctor, primary care doctor, cardiologist. Now, that said, what Sahil mentioned is really the problem. It's this problem of time, the time management, the ability to manage all of the different medications that we know are right for our patients. keeping up to date, especially those of us who don't go to a lot of the cardiology meetings, to keep up to date with the type of data that we're listening to tonight is a little bit difficult, I'd say. And so not only the issue of keeping up to date, having the time to talk to our patients, et cetera. And so the key that I've found, to the degree that I have been able to do this reasonably well, it's relying on some sort of protocols within your office and your practice that are often enacted by your APPs to really make sure that as the patients are getting ready for surgery, coordinating the discharge after the procedure or surgery, that you cover all of those bases. And that's it's an imperfect system, but again, to keep up with this field and all the needs of these very complex patients is tough. The one other point I'll make is that it's anyone who cares for cardiovascular disease in general and vascular patients. All of our vascular patients are at risk not only of PAD, but also of aneurysmal disease, carotid disease. So it's not hard for the patients and the providers to understand the link between all of these different disease states, but it's a different thing to actually enact best practices.
For me personally, I found that it's much easier to have this conversation, because if someone comes in and says my legs hurt when I walk, and I can say this medicine is going to help your legs feel better when you walk, they don't have to be in 8th grade math learning the transitive power, so that you're coming with a leg problem and I'm treating you for a heart problem, so to speak. So I think that I've used it as a way, as part of a conversation, to start using this medicine more often in these folks. But I agree with everybody here so far. We are now going to enter a point where we have to have systems in place to help us bring to bear all these medical therapies, because no one has time in a 12-minute session to have the appropriate conversation for the medications we're talking about. It's just not possible. Marc,
and Josh, can I chime in?
Yeah, please, Darren. Yes.
So I'm going to jump in and put the challenge to the panel and to the audience. Is we've had evidence for GLP-1 receptor agonism efficacy for cardiovascular risk reduction since 2016. So we're 9 years into the data, and why are not sending a person out of your clinic without a prescription for a GLP-1 receptor agonist is like sending them out without a statin. So why is the vascular community so behind the times? We see these data. It's single digit prescription, and you'll see the data from SOUL. You just saw the data from STRIDE, but we've had the data for cardiovascular risk reduction for 9 years. So this is like a statin. It must be prescribed for every patient.
Yeah, maybe I'll just comment. I mean, I think I totally agree with you, Darren. But and then I look at the data from Josh's, analysis from Best CLI, and a lot of patients aren't on the statin either. And I do think it speaks to some of the complexity of who's responsible for caring for these patients. And I'll make a couple comments. One, I do think, as Josh pointed out, drawing attention to limb benefits is helpful, because that's why people are coming to see you. But the second is to the interventional colleagues. We know in the coronary space, a lot more happens when somebody comes in and something happens to them, in their patient journey. They need a revascularization, they have an event. There's just a difference in the inertia around patient care. So they should be getting these in the clinic. But I also think that, when the team gets together around sort of, hey, someone's progressed or they've got symptoms or we're considering intervention, it's a good time to also think about medical therapy.
Darren, honestly, I think the answer to your question, and some of what you're going to address in your second talk, is that nobody in cardiovascular medicine, IR, or vascular surgery likes to give patients therapies with needles. We all avoided that by going into these specialties, and I think, it turns out that it's actually not really a big deal, and it's not like insulin. It's easily dosed. It's not hard to give, but I think that there was a huge upfront amount of friction, because you would tell them that they have to give themselves a shot, and you never had a bland face about it. You'd be like, you have to give yourself a shot, and that's the automatic indication for the patient to be like, I'm not sure. that is a flaw of ours. And in fact, I now think the tide has sort of switched where, I now tell patients, do you want to get on the medication that's the number one drug on the Upper East Side of Manhattan to keep people thin? And that sort of has them jumping forward. So I think, that is changing, but I think needles were the big problem, honestly. Not
Yeah,
who was
and
great at all the
access.
other.
Josh,
and
I
that's
think let's
interesting
be
to hear,
honest.
and Josh, and full disclosure, I take Ozempic. I have type 2 diabetes. I take Ozempic. You can't feel the needle. It's 35 gauge. You cannot feel it go into the skin. The fear of the needle is insane. And what I've heard is I've traveled around presenting the data I'll just show you about the tablet. Probably half of the patients who are resistant to taking an injection are resistant because the psychology of I'm so sick I have to have an injectable medicine, and so we now have an oral formulation. You'll see the data, but at the bottom line is these medicines are cardiovascular medicines, and to send a patient out from a clinic visit without one of these prescribed is like ignoring a statin. We've just got to catch up with the data. Vascular biologists,
Sahil, what were you
vascular
going to? Yeah.
clinicians, cardiologists,
Yeah,
these are our
but
medicines.
we're not talking about the real world, though, are we? I mean, maybe on the Upper East Side, Josh, but in Washington Heights, where I practice, it's a little bit of a different story. And again, the access to these medicines is not ubiquitous, even though they're approved and covered by many Medicaid plans. It is difficult to add the ninth medicine to the regimen. The guidelines have also not caught up. As you were talking about the role of low dose rivaroxaban, it's only now catching on, in part because the guidelines take a decade to catch up with the data, and the guidelines do direct behavior. So I think that I'm guilty as charged. I may be one of those that isn't using it the way we use statins, but I see a lot of patients in the office, and I follow them longitudinally and as their doctor, and I have to make tough choices. So it's not an excuse, but it is an explanation. And I think we would be wise to try to find ways to overcome some of these impediments. I think that's really important to find solutions going forward for how do we incorporate this into the guidelines in a more real-time and rapid fashion. How do we disseminate the information properly, and how do we make it accessible to real patients?
I don't think we have to rely on the guidelines. I mean, these are covered by third-party insurers for most people with indication. As I teach my trainees, the guidelines are for people who don't have the brains or time to read the literature. The evidence has been available since 2016.
Yep.
Yeah.
To let a patient leave your clinic, let a patient leave your clinic without you can prescribe it, maybe they can't get it, and I get that, but the fact that cardiologists and are not prescribing these medicines it's an embarrassment.
Yeah, Darren, I agree. I mean, but I do think it's not just in the vascular space, in cardiology in general. I think a lot of people have sort of resisted. Maybe these data help reframe, your data from SOUL and STRIDE, that these aren't diabetes drug with cardiovascular benefits. These are cardiovascular drugs. And the other thing I'll say, Sahil, I think you're totally right. There's polypharmacy, and we have to choose. And I have to say, I tend to think of like, if I can't prescribe everything, what's going to give you the biggest bang for the buck? And so then, I do think the data that we're talking about today helps prioritize, why you might use this earlier than you might have before, because you can actually make people live longer, feel better. You make their kidneys work better. There's their sleep apnea is better. There's all sorts of stuff. Plus people like losing weight if they need to. So maybe this helps disseminate some of that. But I think you're spot on that it's a complex problem, and polypharmacy is a real issue.
Yeah, I totally agree with that. And to the comment about nine pharmaceuticals prescribed, this class of medicines should rise above at least 7 of them.
All right, I want to bring this section to a close. I want to ask one more question of Marc. Marc, Marc, it looks like the curves continue to separate as the trial goes on. Psilocybin peaked and plateaued. Do you think that the benefit will continue, the curves would continue to separate? Is that how it was looking in the trial?
Yeah, it's a great question. There's more to this than Sahil making you feel better. I mean, the ABI change is real, and the curves continue to diverge, and so I do believe that there's a disease modifying impact here. I don't think we saw any plateau. In fact, when people were off drug for 5 weeks, they still had better function. So I do think, and we didn't study it, but I do think the benefit is continual. And actually, I think Darren will show us in the next section of whether that translates into longer term, benefits in the legs. But I do think that the benefits would continue over time, and that this magnitude represents 1 year of therapy, not long-term therapy.
Perfect. Let's move on to our
Josh.
next talk, Dr. McGuire. Oh, yep.
We have one question from the question and answer chat. What is the purported mechanism by which GLP-1 receptor agonists produce effects on PAD and small vessels, absent or irrespective of weight loss? Does anyone want to take that real briefly before we move on?
Maybe we want to
Marc,
tackle that after Darren's presentation.
Let's talk about that after the.
All right.
I agree, that's good. We'll talk about the mechanism afterwards. All right, let's hear Dr.
Sounds
McGuire's
good.
talk.
Hi, I'm Dr. Darren McGuire, cardiologist at UT Southwestern, and it's my pleasure to present the primary results from the sole randomized trial of oral semaglutide in people with type 2 diabetes and high risk for atherosclerotic cardiovascular disease on behalf of my executive committee, the trial sponsor, and the participants in the trial. So oral semaglutide was formulated to overcome some of the clinical resistance to taking injections. We've seen a number of positive randomized clinical trials with injectable GLP-1 receptor agonists favorably affecting cardiovascular risk. These have entered the product labels and the guidelines for cardiovascular care, but it's estimated roughly half of patients who have access to and indication for the injectables are not taking them just because of the injection part of the therapy. So oral semaglutide was developed to overcome this clinical unmet need. So we randomized 9,650 participants with atherosclerotic cardiovascular disease or chronic kidney disease who had type 2 diabetes and age 50 or greater. Our primary outcome in the trial was cardiovascular death, MI, or stroke. Patients were randomized to get placebo-controlled oral semaglutide starting for 4 weeks at 3 milligrams, titrated at 4 weeks to 7 milligrams, and ultimately 4 weeks later titrated to the target dose of 14 milligrams once daily of oral semaglutide. This is the dose that's presently approved to treat hyperglycemia in type 2 diabetes, and also has a previous trial demonstrating cardiovascular safety, but not efficacy. So the sole trial was to take that one step further to test for superiority of oral semaglutide versus placebo on cardiovascular outcomes. Our primary outcome, as I mentioned, was time to first event of cardiovascular death, MI, and stroke. Our prioritized secondary exploratory outcome was a 5-point composite outcome of kidney-related outcomes, followed by cardiovascular death, and subsequently a confirmatory outcome of major adverse limb events, which we defined in the trial as hospitalization for acute or chronic limb ischemia. We did a number of exploratory analyses of the individual components of the composites, of inflammatory markers, and of metabolic parameters. This is the disposition. We had perfect balance randomization of 9,650 participants. Over 98% completed the trial. And those stopping study drug early, represented at the very bottom of the trial, was higher in the placebo group than it was in the oral semaglutide group, underscoring the tolerability of oral semaglutide, and this reflects most likely the fact that hemoglobin A1C was being monitored and managed in an open label fashion. People in the placebo group were coming off investigational products so that they could be treated with open label GLP-1 receptor agonist. On average, patients were 66 years old, 3/4 were men, average A1C was 8%, BMI was 31%. These individuals in the trial had an average duration of diabetes of 15 years. And the ASCVD and EGFR representation is at the bottom of the slide. EGFR on average was 74. high sensitivity CRP at study entry was 2, right at the normal threshold or abnormal threshold. And importantly, over a quarter of the patients were being treated with SGLT2 inhibitors at study baseline. And during the trial, an additional 25% were started on SGLT2 inhibitors. So we have an exposure of 50% of trial participants getting SGLT2 inhibitors on top of the randomized placebo-controlled oral semaglutide. The primary outcome, cardiovascular death, MI, and stroke, occurred about 14% over a 54-month period of time in the placebo group. This was reduced with oral semaglutide by 14%, statistically significant 14% reduction, hazard ratio 0.86. So the primary outcome of the SOUL trial was positive. And I'll remind the audience that the 0.86 hazard ratio is exactly the hazard ratio from the pooled analysis of previous injectable GLP-1 receptor agonists, so putting oral semaglutide squarely into the class effect space of GLP-1 receptor agonists for cardiovascular risk mitigation. Our prioritized exploratory outcome in the hierarchy, 5-point major kidney disease, that was cardiovascular related death, kidney related death, EGFR reduction greater than or equal to 50%, persistent EGFR less than 15%, or chronic kidney replacement therapy, was directionally favorable, a point estimate of 0.91, but the confidence interval crossed unity. The p-value was not significant, and therefore all subsequent analysis become exploratory. Cardiovascular death alone, again, directionally favorable, but again, not achieving nominal significance with confidence intervals crossing unity, a point estimate for cardiovascular death of a 7% risk reduction. Interesting, peripheral arterial disease events occurred less commonly in those taking oral semaglutide versus placebo. The curve separated relatively late after 24 months, but continued to diverge through the rest of the trial. Again, this is a composite outcome of hospitalization for acute or chronic limb ischemia. So the confidence interval here excludes unity, a point estimate of a 29% relative risk reduction, raising the hypothesis that oral semaglutide reduces PAD-related events. Supportive secondary outcomes across the individual components of the cardiovascular composites all were directionally favorable, as you can see here, fairly consistently across the spectrum of outcomes analyzed, supporting the generalizability and the broad spectrum clinical benefits of oral semaglutide across cardiovascular risk outcomes. Subgroups pre-specified, stratified by sex, age, BMI, A1C, EGFR, region, and SGLT2 inhibitor use at baseline were all fairly consistent directionally. There is some statistical interaction by region, where in the North America region, there is less effect, as in Europe as well, but Asia and other regions driving that result. We think that probably has most to do with adherence to investigational product and not because of differential efficacy by region. We were concerned about this oral formulation of semaglutide getting actually pharmacodynamically effective doses to the patients. This is a unique tablet that has to stick to the gastric mucosa, should be taken on an empty stomach with less than 4 ounces of water and with no oral intake for 30 minutes. And so we weren't sure if a patient population of 10,000 people could actually do this over a period of 4 to 5 years. And we actually demonstrated that, in fact, they could. Hemoglobin A1C was reduced, body weight was reduced, CRP was reduced, as is expected with GLP-1 receptor agonist therapy. And so these biometric parameters reinforce the fact that the patients were actually able to take and get a pharmacologic dose of the semaglutide with the oral formulation. So in conclusion, oral semaglutide was superior to placebo in reducing the incidence of 3-point MACE, that's cardiovascular death, MI, and stroke in people with type 2 diabetes, with atherosclerotic cardiovascular disease and or chronic kidney disease. There were consistent cardiovascular efficacy of oral semaglutide across subgroups by sex, age, BMI, EGFR, and concomitant medication. The overall safety profile of oral semaglutide in SOUL was similar to that observed in previous clinical trials with semaglutide, and no new safety signals were found. The trial results add to the favorable benefit-risk profile of oral semaglutide in this population. And I'll remind the audience, the point estimate of efficacy for 3-point MACE of 14% relative risk reduction is exactly what was observed in the previous pooled analysis of the injectable GLP-1 receptor agonist, putting oral semaglutide squarely into the GLP-1 receptor agonist space. This is the only oral formulation of GLP-1 receptor agonist that has cardiovascular efficacy proven. It's not yet product labeled, but the regulators will be reviewing these data, and we fully anticipate a product labeled indication for cardiovascular risk reduction that will parallel the previous GLP-1 receptor agonist. So thanks for the time, and I appreciate the opportunity to present these data.
Excellent. All right, so now that we're back to the panel, let's go to the question that was brought up by the person in the audience. What do you think the mechanism is? Does anyone want to start off and guess? I have a few thoughts myself, but what does everybody? Let's do it this way. Does anyone have a thought as to what the mechanism of benefit is? And I guess I'll start this off by saying, Marc, was it all weight loss in STRIDE?
Yeah, I was going to say we could start saying what it isn't. It's not glucose lowering. We know that both for the MACE benefits and for the limb outcomes. Darren can speak to this. He's one of the world's experts in this area, but certainly for the functional outcomes, the glucose lowering was modest, and other glucose lowering drugs don't do this. It wasn't weight loss. Weight loss is part of the story. Actually, we're presenting data at the ADA. It is true that if you have a very motivated patient who loses weight by exercising, they will also walk better because exercise makes you walk better. The weight loss related to semaglutide was very weakly correlated, so it wasn't that. I think we can all talk about different potential mechanisms, but I strongly suspect that anti-inflammatory effects play a key role here. So I'll let others sort of comment now.
I'll take on where Marc left off, and I think the anti-inflammatory effects of these drugs are pretty profound and pretty acute, and we've seen in other GLP-1 receptor agonist trials that ASCVD unstable events are affected acutely. It's not like the LDL modification where we have to marinate in the new LDL for a year before we see the curves separate. So I think that's probably it, but I will take one step back. And for the clinicians who are asking what's the mechanism, I would say, who cares? I mean, if you have different clinical outcomes with one therapy versus the other, we don't need to care about the mechanism as much as we need to get the therapy prescribed. The how and the mechanism informs further research if you want to target novel therapies, not novel targets. But I lecture on this all the time, and I get quite frustrated when people, if they don't understand how, they're resistant to prescribe the medicine. And I will remind you that SGLT2 inhibitors and empagliflozin at the FDA meeting, every one of the 8 endocrinologists voted not to approve empagliflozin because they didn't understand the mechanism. It's like, we have to let the mechanism go and let the scientists figure that out, but at the same time in the clinic prescribe the medicines proven with clinical efficacy.
I think I will say this. I think there's two separate issues here. One, I agree that demonstrating that it works in a large randomized trial is enough to verify and substantiate its use. Understanding the mechanism actually helps people use the drug, as you can tell by the, weird response by the FDA panel, but also by other people we just speak to. It also helps us figure out how to move forward on different trials. Like, I think the understanding, and this is heresy where I work, but the idea that statins reduced inflammation at the time of an acute coronary syndrome really pushed anti-inflammatory science and then therapies forward. Now, for GLP-1 receptor agonists, we published a study using liraglutide where we also had a weight control population and a DPP-4 population. And this was the only drug that improved endothelial function in patients who had insulin resistance. GLP-1 receptors are actually found on endothelial cells and vascular smooth muscle cells. And there was a small trial recently that demonstrated that the use of these drugs improved TCPO2 in patients with severe PAD. So there may be also a microvascular benefit as well as a large vessel benefit. I don't disagree with anything that anyone said. Trying to understand how they work will maybe help us move to the next kinds of therapies and it's not a comment on whether we should use the drugs. But I think understanding the mechanism also helps us understand what's going on disease-wise with our own patients. All right, so we went through and we had a conversation about how needles make it more difficult to give the drug to patients because there's more friction both from docs and from patients. And even though it's actually not that difficult, that does not, it's also not difficult to give statins. And I have patients who apparently access the internet who think that those drugs are poison. So do we think that having an oral version will make a significant difference? Is it going to be easier? And I'm going to ask the folks who've been relatively quiet. So Daniella, Tino, and Brian, would you be more willing? Do you think the conversation would be easier to give these medications orally?
I think it depends on the patient. I mean, I think the downside with the oral is this delay between taking the drug with a small amount of water and then being able to eat. Although it was reassuring to see that so many patients were able to do that in the study. But it's going to have to be on an individual basis. There's some patients who would prefer to take the weekly injection and not think about it all week. So, I don't know. I do think back to our earlier discussion, part of the reason why these drugs are underutilized is people feel like it's not my organ. Clearly, we have the data to show it is our organ and all of our organs. But at minimum, if we're not going to prescribe them, I think these medications should be making it into our note and recommendations for the providers to implement for our patients if we're not going to do it in the office at that time.
I'll push back a little bit. Why would you not do it in the office? Do you defer statin prescription to other providers?
Not at all. No.
I mean,
but
these
I
are
do
these
think
are
that
cardiovascular medicines. These are cardiovascular medicines. They
you're
have to
not
be part
wrong.
of our everyday practice,
I agree with
right?
you, but I also think when patients come in with a myocardial infarction and get a stent, the primary care physicians are looking at cardiologists say to do with DAPT, for example, and follow that. So I agree with you. I think that we need to be prescribing that, but in addition, or if you're not going to be comfortable prescribing it, it needs to make its way into your plan so that people realize that that's the recommendation and that's what should be happening.
Yeah,
I
I
think the
don't buy
heart
that.
failure.
I don't think it makes it into your plan. I think it makes it into your prescription. And I don't. I'm sorry, Josh knows me. I'm very controversial, but it stuns me that we're 10 years out from the data and our cardiologists are not prescribing these medicines. These are not for the primary care. These are not for the endocrinologist. These are cardiovascular medicines, and not prescribing them is like not prescribing antiplatelet therapy or a statin. These are our
Yeah,
medicines
I
as
agree with you,
cardiologists.
Darren, but I don't disagree with you, but I'll say one of the things the heart failure docs have done really well is to demonstrate that starting these medicines in the hospital, for example, when you meet patients there, they're much more likely A, to get them, and B, to stay on them. That kind of data is there for DAT. That kind of data is there for statins. And I would say the next threshold to really get these medications into patients is that anytime they're in the building, for whatever purpose, we should demonstrate that using them there has a significant benefit. B, it's not, you shouldn't avoid starting them in the more acute situations. And B and C, if someone goes out of the hospital on a medicine, they're much more likely to be on it A, in a year, and B, their primary care physicians will see that it's tied to these events. I think that our implementation of the data has been poor. And I think part of the reason, as we talked about before, was that it was all needle based. And I think that was really hard to get people to give, even when they have never given any other needle-based therapies until the PCSK9s. And we can see how well those have been taken up. That's taken a while also. I think we are changing over things now. I think people are becoming far more comfortable, as our prescribers are on these drugs and can just attest to the fact that, actually this is not really a big deal. It's probably easier just to take a once a week or once every other week medicine.
Yep.
But
I
I
was
will
going to
tell
say
you
that.
that, yeah, I think that I think that there's a lot of, I think there was a lot of friction because it was a needle-based therapy, not because they didn't want to give it. Also, and I don't disagree, the guidelines, yes, I think all medical information is ahead of the guidelines, but you can see what the PAD guidelines said in 2024. It didn't get a class 1. Even it did as a diabetes therapy. But Select would suggest it doesn't. You don't even have to have diabetes to get a benefit
Right.
from these drugs for
That's a
cardiovascularly. So, yeah.
that's a
So
guide.
I
That's a
think that
guideline writing committee I want my money back from. In 2024, the data were so ample. Why is that? But here's the deal for the injection. Let's be clear. It's a 35 gauge needle. You cannot feel it enter the skin. You don't need to alcohol swab. It is the fastest, easiest administration. And even though I chaired the sole trial of oral semaglutide, it should be injectable every time. And there should be no resistance. You
right.
can't feel it enter the skin. I mean, it's comical how people are so resistant to this injection therapy. And since for 20 years, the World Health Organization has discouraged alcohol swabbing for small volume injections, so you don't even have to swab the skin. Bare skin, stick it in, you're done. It's 30 seconds.
Yeah.
I don't think anyone disagrees. I think we have to teach people how to do it. Let's as we're coming closer to the end, let's let some of the other folks jump in. Brian, Tino, Sahil, Daniella, tell us where you're going to go from here with this data.
I had a question before I go there, and that is, do we think because it's tied as a weight loss medication hurts us? Does that hurt us to get it approved? Does it hurt us to get it from the insurers, to get it on the guidelines, to make it accessible?
So actually for diabetes, it's not that hard.
No, I'll just say, I think how you write the prescription and what you write for does impact whether it gets covered. And so you have to be careful. Like, it's covered for diabetes, as Darren said, it's covered for actually the select criteria. We get coverage for that. If it's written for obesity, it doesn't get covered. And so one thing I think that is a barrier, and Sahil made this point, is coverage. And one thing we can do together is sort of share language of like, what do you need to put in your note and how do you write the script to get it covered? Because it actually makes a big difference in terms of what you're facing after in terms of prior authorization stuff. I also wanted to comment, a lot of people are prescribing PCSK9 injectables without an issue, I think more than this drug. And so I don't think it's just the injection. And I want to be fair that I do think these drugs were rolled out as diabetes drugs. I mean, they're not, but that's how they were sort of initially studied and rolled out. And, in our own institution, there was a lot of, with the endocrinologists, like, well, be careful if they're on insulin too, because you have to adjust the dose. There was a lot of this sort of, I think, fed into this. Hey, let us deal with the drug class. Now, this is 5 years ago. I mean, Select, I think, changed everything, and now Sol and Stride. But I do think there's a legacy of how these drugs were rolled out that has made it harder to implement in the cardiovascular space.
And to add to that, there's
All right,
a
does
lot of
anybody want to
people
say
who
anything?
are.
No, go ahead. Sorry, Danielle, go ahead.
I was just going to say that's okay. No, there's a lot of people who are the sole vascular provider for patients who are not cardiologists, who are vascular surgeons or interventional radiologists, and may not necessarily, I guess that's a lot of where my comment was coming from. I don't think you're wrong. I think that it's an easy drug to prescribe, but, any change is difficult to make, and there's going to be a lag time. I think with this data, we have a lot of reason to implement these therapies now right away.
All right, Brian, Brian or Tino, you're gonna get the last comment.
Yeah.
Go for it.
Well, I would say the same thing. I remember when we started writing, statins, and when we started writing rivaroxaban, it took a while to get us going. But I think the data is there, and I think there is a strong reason that as we see these patients, especially those patients that we see that may not have that many other providers, or that may see you as their primary provider, how it's important to get the word out, get it, start prescribing it, and let the other physicians know, or potential physicians know, why you're doing it, and get things going. And I think that's how you start the movement.
Agree. That sounds great. We are now a couple of minutes over. I want to thank everybody for participating. This was a really great conversation. We had a lot of active and interested viewers because of the quality of our discussion. I think we can skip the slides. They're not necessary. We covered every one of the topics that we asked people about. The one thing I'll say is that we have a lot of therapies now that can improve limbs as well as lives. And as you heard the data tonight, I think we should start to do, we don't have to wait until 2040 to get our stuff in. We should probably do it next week. And with that, I'll say thanks to our presenters, thanks to our panel, and thanks to you for coming. From headquarters, thanks for coming to the Data Deep Dive. Have a good night.
Good night, everyone.